Welcome. Today, we're diving headfirst into the high-stakes world of the surgical viva. We're going to walk through a classic trauma case, step by step. But this isn't just about memorizing answers. It's about learning to think clearly and systematically when you're under pressure. This is where you show you have the judgment of a consultant. Let's get started. So here's our roadmap. We'll start with how the case is presented. Then, we'll hit the primary survey, the ABCs. We'll make that critical call to go to the operating room, see what we find inside, and figure out what to do about it. Then, of course, we'll manage a complication and finish up with a final rapid-fire challenge from the examiner. Ready? Let's go. All right, the clock starts now. The examiner kicks things off. You know, this first question is all about seeing how you react right out of the gate. They're looking for a framework, a system. They want to know you have a safe default setting for chaos. And there it is, the classic opener. A gunshot wound to the abdomen. The examiner isn't just asking what you do. They're listening for how you'd think. They're waiting for a few key words that signal you're in control and following a proven system. Perfect. That's the money phrase. By saying ATLS protocol, you're immediately telling the examiner that you're not going to cowboy this. You have a structured, internationally recognized plan. It's the safest and most impressive way to start your answer. It sets the tone for everything that follows. Okay, so you've said you'll use the ATLS protocol. Now you have to prove it. The primary survey is all about finding and fixing what's going to kill the patient first. It's that classic, non-negotiable sequence: airway, breathing, circulation. And the candidate nails it. Airway, the patient's talking, so for now, it's clear. Easy check. Breathing, get him on oxygen, make sure he's saturating well. Check. And now we get to the heart of the problem in this case: circulation. This is where the action is. Okay, let's break this down. The heart rate is up and the blood pressure is on the low side. That's shock until proven otherwise. We've got 2 large IVs in and fluids are running. Now notice the abdomen is tender. That's a huge clinical sign. And don't get fooled by that negative fast scan. It's not great for picking up bowel injuries. The real story here is the patient's vitals and the physical exam. Something is wrong inside that belly. So, after a liter of fluid, the blood pressure gets a little better. This is a classic exam scenario. We call this patient a transient responder. It means the fluid helped for a minute, but the leak is still ongoing. You're filling the tank while it's still got a hole in it. The fact that the secondary survey is clear just confirms our suspicion. The abdomen is the only problem. And here we are. This is a massive decision point in the viva. You've gathered the initial data. Now the examiner is watching you, waiting to see if you'll be decisive. This is not the time to hesitate or ask for more tests. You have to make the call. The examiner puts it to you directly. You've got a penetrating injury, you've got signs of shock that only temporarily improved, you've got a tender abdomen. What is the single, definitive, life-saving next step? Exactly. That's the only right answer. There is absolutely no role for a CT scan here. A gunshot wound with peritonitis or hemodynamic instability is a ticket straight to the operating room. Making this call confidently and quickly scores you major points. So, we're in the OR. The game changes now. The examiner is no longer testing your resuscitation skills. Now it's all about your surgical judgment and your technical know-how. We open the abdomen, and here's what we see. The bullet has peppered a 50-centimeter section of small bowel. Lots of holes in one place. But, and this is important, no other organs are damaged. The bullet's journey stopped before it could cause any more trouble. This really helps narrow down our options. The examiner wants to know your surgical plan. You've got a bunch of holes clustered together in one segment of bowel. What's the smartest, safest way to handle this? Yes, the correct move is to resect that entire injured segment and then join the healthy ends back together. Why? Because trying to oversew every single little hole is slow, risky, and you might miss one. Plus, it could lead to narrowing of the bowel down the line. A clean resection and anastomosis is the elegant and safe solution here. Now, don't relax just yet. A great candidate knows that the case isn't over when the surgery is done. Examiners love to throw in a post-op complication to see if you can manage the entire patient journey. And there's the curveball. A few days post-op, things are going wrong. This description, foul-smelling, high-volume discharge from the wound, is a dead giveaway for a very specific and serious problem. First, you have to name it. That's right. After investigating, the diagnosis is an enterocutaneous fistula. Basically, the anastomosis has leaked, and an abnormal tunnel has formed between the gut and the skin. This is a huge management challenge. You've got digestive juices eating away at the skin, and the patient isn't absorbing any nutrients. Now for the big question. The examiner is looking for a structured plan. This isn't just about surgery, it's about nutrition, infection control, wound care, and managing fluids and electrolytes. You need a comprehensive, multidisciplinary approach. And this answer is fantastic. It covers all the bases. You start by resting the bowel with IV nutrition. You control any infection with antibiotics. You protect the skin, and you replace lost fluids. Crucially, you give it time to close on its own, because many of them do. And you only plan for surgery if that conservative approach fails. That is a complete consultant-level plan. Just when you think you're done, the examiner hits you with some rapid-fire what-if scenarios. They do this to test the breadth of your knowledge and to see how you think on your feet when something unexpected pops up. Okay, first twist, an associated injury to the bladder. The answer needs to be immediate and precise. This requires a formal 2-layer repair of the bladder wall to make sure it's watertight, followed by placing a urinary catheter for a couple of weeks to let it heal without any pressure. And for the grand finale, a really tough one, an intraperitoneal rectal injury. This is a far more complex problem because of the high risk of contamination and serious infection. There's no single right answer here. It depends on the size of the injury, how stable the patient is, and how contaminated the abdomen is. The options could range from a simple repair all the way to resecting the injured part and creating a diverting stoma. It's a challenging scenario that forces you to weigh multiple factors, which is exactly what surgery is all about.